Hello and welcome again to another Down Fracture podcast, a podcast for talking jaws. This is Dr. Michael Wasson here as usual, Dr. Sam Bobek. Sam, what's going on, man?
Not much. We have a guest today, so it's kind of nice to not just talk to you. I was getting tired of that.
I also get tired of talking
I
to me
bet.
and listening to me. Yeah, we do have a guest. I would even call him a special guest because that's just how much he means to me. Maybe he doesn't mean as much to you. Well, let's do our basic housekeeping. Downfracturepodcast at gmail.com. We do read it. We do like it, especially the negative stuff directed towards Dr. Bobek. If you have suggestions, cases, topics, please let us know. And then, Sam, it did not turn out to go how we wanted in the College World Series. How are you feeling about that?
We didn't have to make a trip. I was bummed. The Beavers, I think, dropped out before you guys did. Your
Well,
ending was
yeah,
painful. Omar, before we introduce
that's
you, do you watch college baseball at all?
No,
Did you see the
this.
highlights of Arkansas losing that game?
I did not. What happened?
We don't
Oh,
have to talk about it.
it
Um,
was brutal. Oh, I felt so bad for left fielder. It was hard. They're just I used to be a Cubs fan. I guess I'm still kind of a Cubs
oh, me too. How I
fan.
didn't know that about you.
Um, and the Cubs would just lose in like these ridiculous, painful ways that it just seemed like the baseball gods were against you, and you just accepted it. All I got out of the Arkansas is they must have been cursed by the baseball gods as well, because that was sad.
Well, yeah, you remember the series when we played you guys in what 2017 that we talked about last time? Like
Yeah,
had it wrapped up and then just gave it away.
that
But
hurts.
yeah, but I am going to use our extensive universal platform here to kind of maybe vote some reform. Like, why don't they reseed when they make it to the College World Series? Because the two best teams, well, I think it's pretty clear the three best teams were Arkansas, LSU, and Coastal Carolina. And you had the two highest ranked teams on the same side of the bracket and having to play each other in the first round. Like, why don't you put them on opposite ends and have that as the championship? Like, not only were they the two highest seeds, they're in the same
It
conference.
doesn't matter. The baseball gods would still take Arkansas down.
Yeah.
So
Yeah,
you're
I'm not
hosed
saying
no matter
Arkansas
what
would.
happens.
Yeah, LSU was the better team. They would have won, but like just for viewership and like why do you have like think about it from Arkansas's perspective. Hey, you're the number three overall seed, and you basically haven't lost to anyone outside of the SEC all year. And here, you've already swept your regional, you swept your super regional, including having to beat another SEC team, number 14. And here's your reward as being the top rated, highest remaining seed. You got to play the second highest seed, who's also in your conference and, had already played them in a series this year. Like it just doesn't, they should reseed them, I guess is what I'm saying.
I'm feeling like it's therapeutic that you got that out. So
It is.
I
It is, but
mean,
I think it's a real thing. Like, because, like, I mean, think whoever was in whoever won that Arkansas LSU game was probably going to win the title, and that's the first game. Like, what's the point in that? Like, if we would have been in the bracket with Oregon State and those other crappy teams, like we
just sounds
probably
like
wouldn't
some
have even.
SEC garbage that I'm hearing right now. So
Well, when you win seven straight natties, you get to have that kind of privilege, so to
there
speak.
it is. Let's see. Let's find out about Omar. Omar joined us today. I think. Are you doing the intros? Hopefully.
You could do it. I mean,
I don't know
whoever he can
Omar's
introduce
background. I
himself.
mean, um,
I can introduce myself. It's fine.
how
Let's
about
do
that?
it.
All right.
Let's see.
First of all,
Omar,
Floor is yours.
I want to get the old man saying out of the way. I'm a long time listener, first time caller here.
nice. There it is.
Yeah, just check that box.
He knows what we like.
Big fan of the podcast. But yeah, my name's Omar. I finished up residency 3 years ago. I went to UT Southwestern Parkland Memorial Hospital. And I guess today I'm going to talk as an expert about what that transition is like going from residency into what I consider like a full scope private practice. Currently in Los Angeles, work full time here at LACOMS, or the Los Angeles Center for Oral Maxillofacial Surgery. And yeah, very fortunate to be in a group that offers the whole gamut of of oral surgery, and especially corrective jaw surgery and TMJ and trauma, which I guess this podcast is really kind of focused on.
Yeah, so Omar, thanks a lot for joining us. I appreciate taking the time. We've received some feedback from you over the months of us doing this, and it's good to get that sort of thing. I was excited to talk to you because it's rare to have people who are right out of residency to get going on orthognathic surgery and have as much interest as you do. So I'm pretty excited to meet a real life young orthognathic surgeon and kind of hear about your experience. Did you always know you wanted to do jaw surgery, or did you figure that out in the middle of all the other crazy stuff you were doing at Parkland?
Um, I think towards the tail end of residency, I realized that corrective jaw surgery is just like awesome. Like the operation is fun. I love operating on bones, like whether it's trauma or sagittal split or a LaFort. And it also is pretty life-changing for the patients, correcting malocclusions, asymmetries. And it's just long enough of an operation. The cases were a lot longer in residency, but some of those cancer cases where it's like 12, 14 hours, just exhausting. Corrective jaw surgery can be
I mean,
a
that's Wasson's normal time for a sagittal osteotomy currently. He's
Just
got it
one
down to
side.
12.
yeah.
One side.
Some people do it in 45 minutes, I guess, on social media and stuff. But
Yeah,
Oh
that's
man.
great. So you were telling us you were considering some different routes, and we've talked a little bit about those before, but you ended up with LA Comms, which is, if people don't know, that's a great practice to be seen and have orthognathic surgery. There's some excellent surgeons there, and so bringing on additional excellent surgeons makes sense. But how'd you end up on that versus the alternatives?
yeah, so I guess I'll start in residency. I did the classic thing where you start residency and you're already thinking about fellowships and what you want to do next, and cancer, cosmetics, craniofacial. So I went through that whole route. And then by fourth and fifth year, I started looking for jobs more seriously. And I kind of understood that fellowship was not the right thing for me and my family. I just had a kid, and my wife was kind of over the training as much as I was. Um, and that's when I, started sending feelers out. So people ask, like, how do you find the right job, or what's the best way to find a good fit? And I think the key is just knowing where you want to live. And for us, me and my wife, it was either Dallas, Texas, where we were for residency, or Southern California, where my parents, my in-laws are. And so, starting in fourth year, I sent a bunch of emails out to pretty much any oral surgeon I could find when I, Google oral surgeon Southern California, and just say a little introduction. I'm finishing in summer of 2022, looking for work, etc. I probably sent like 50 emails, and maybe like 2 office managers responded, and nothing came to fruition from that.
You sent 50 emails, just cold emailed people. Is that a term? Cold email? Cold
Yep.
call?
Cold
Yeah.
call, yeah.
Um,
I don't know if maybe I'm exaggerating. At least 30 for sure.
okay.
A lot of
30 is still a ton.
It's a lot of emails because it's a very competitive market in Southern California. And you don't know unless you ask. And I was kind of interested that it was kind of interesting. I didn't get a lot of responses, not even like, oh no, not at this time. Like, thanks for asking. It's just like no response. And then I started considering the academia route, which I think for most residents, we recognize that doing like full scope oral surgery, if that's your interest, is the path of least resistance is through the academic route. That is where you can go, and from day one, you'll have pathology, trauma, TMJ, and orthognathic cases available to you. And so I applied and interviewed at an academic institution, and had a lot of interest in that. But at the same time, there was multiple things kind of happening at the same time. There was another opportunity in a private equity backed private practice in Texas that kind of dabbled in corrective jaw surgery. And, I met all the partners there, and they were all awesome. But what really turned me off was the fact that they had already sold or partnered with a big private equity company, which, from my limited understanding, is not really ideal for a young surgeon just starting out in practice. It's more kind of geared towards those people towards the tail end of their career, the golden parachute per se. So I did explore that as an option. And then there was also a managed care model here in the West Coast that focuses on, TMJ and orthodontic surgery exclusively. And
And
that
that's
was
Kaiser,
really,
yeah.
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 And so they do a lot of jaw surgery, and the compensation was really competitive, especially for just starting out. Something that anyone who looks into that kind of opportunity will notice is that you're literally just doing OR based procedures. Like you're not taking out teeth unless if it's like for cancer cases or dental clearances. You're not placing dental implants. You're not sedating your own patients. So you're really kind of pigeonholing yourself into jaw surgery, TMJ, and some pathology. And so, for that reason, that wasn't really ideal for me. And honestly, the opportunity here at LA Comms just kind of fell into my lap. They posted about they were looking for somebody on the Amos Career Line website, and I had a connection through my residency program. One of the partners here was there at the same time as me, and I interviewed, and obviously I had known about this practice from being born and raised here in Southern California, doing dental school here. I knew it existed, and I knew that this is a place that I would really like to be. And yeah, started here 3 years ago and haven't looked back since.
Nice. So you mentioned that you're also doing trauma. Are you guys taking call at a level one, level two? Like, what's the situation there? How's that split up? Are you dumped on as the junior guy?
Hopefully.
Yeah, it's funny. So we have a level one trauma center here in Los Angeles, Cedars-Sinai Medical Center. It's like in Beverly Hills, like right in the thick of it. And our group here takes all the facial trauma call, and basically me and one of my partners split it 50-50. So when I first started, I had to go through the credentialing process, and there was probably about 1 year time period where I was doing a vast majority of the call. But we don't really look at it as a burden. Like honestly, that trauma call, yeah, is the classic, waiting 3 or 4 hours to get an infection started, to like 10-minute case and you're around the hospital for 3 or 4 hours, or working weekends. And a couple of weeks ago, we started a case at 2 in the morning. We had two trauma cases that we started at 2 and we didn't finish till like 6. And then you take a shower and go into the office the next day for a full day in clinic. Like those days happen, and they're difficult, but you also get to stay sharp. And I think operating trauma is a really, really good place to learn, foundational skills of broad scope surgery, putting screws in, access to the midface and the mandible. Those are all things that you can kind of practice on trauma cases and then apply them directly to jaw surgery or TMJ surgery.
Definitely.
So it gets busy at times, and sometimes it's super slow. It really just depends on the time of the year.
I mean, I would think a level one trauma center, I mean, would be fairly busy.
A lot of non-op fractures, sinus fractures, non-displaced orbits, CMCs, arches. Um, I was trained to open a lot of subcondylar fractures, and we do that, but you know how it is. Like not every subcondylar fracture or non-displaced, even a symphysis in a compliant patient. A lot of times they'll just observe those cases. I have a patient right now that I just saw for a 3-week follow-up. She's a non-displaced symphysis subcondylar, and she's actually a physician at the same hospital. And liquid diet, initially soft foods, and we're just kind of monitoring the bite. So it's a lot of outpatient follow-up.
Yeah, trauma's great in that regard. It's the patient already breaks their bones for you. It's pretty nice. All you gotta do is put placement screws and align it. Because I
Yeah.
mean, that is part of orthodontic surgery, right?
Absolutely.
The steps of putting it back together, putting it in the right spot, and then putting it back together has complexity to it. And you're also designing the cuts and initiating the original fracture. Practicing with trauma is definitely insightful for residency and early out of practice, because it just takes a while to grow an orthodontic practice, right? Like, because I assume you're helping out as an assistant in surgery, and that as you grow your own practice, is that how it's working?
Yeah, so our model here is we have two surgeons in every case. There's the primary surgeon and the co-surgeon, and it's essentially split 50-50. It just depends on which side you're standing on. having that co-surgeon model is just so fun. And I know you guys have talked about, I know you like breaks and, um, you guys have talked about that on other episodes, but having like another capable set of hands, whether that's a highly trained physician's assistant or a nurse practitioner, whatever it is, it just makes your life so much easier, makes the operation so much more enjoyable. Um, and especially for me, my co-surgeons have decades of experience more than I do, so it's really nice to be involved in that model early on. And then yeah, I have my own cases that come from my friends in the community that are orthodontists here, or patients that find us online. Um, so there's opportunities there for like me to be the primary surgeon, but definitely takes time. And I it's kind of like I'm trying to start my own orthodontic surgery practice next to the largest names in orthodontic surgery for us in Southern California. So um
Yeah, because I think
but yeah,
that is a like a turnoff to people, right? Like they're worried about being able to get some cases. I've always seen it as like a way to access cases, though. Am I wrong in that, or?
I think it depends on the practice and how supportive they are. Um I mean it's gonna sound like an ad here, but I mean it's yeah, we're not hiring right now. We just hired another person, but this is the best place to come out and be exposed to this type of surgery and get hands-on and do this type of surgery. So I'm very fortunate. They're very supportive. Like I remember my first week here, there was a patient that had just gotten off the plane from somewhere in South America, and the consult was for like a osteomyelitis of the maxilla. And the patient comes to LA Comms, they probably thought they were seeing Rob Relly or Ben Wallin or one of my more seasoned partners, and they see Omar Kholaki, 1 week out of residency. And he had like a avascular necrosis of his whole entire left maxilla. 18-year-old kid, big underbite that was treated, somewhere else. And they did an isolated, Lafort advancement. I mean, I'm talking about like a 17 millimeter advancement. The guy looked really bimaxillary protrusive and had a fistula. And so I treated that patient for basically 2 years, start to finish. And interestingly, I had seen a couple avascular necrosis cases in residency. And so I was like the expert of avascular necrosis here in the office. And
There you go.
I had the opportunity to kind of treat that patient, but I could have very much seen them being like, hey, this is a little bit above your pay grade. Why don't you, let us take care of this case? But no, they let me kind of do the treatment planning and execute the operations. And so they're super supportive. So I think it really depends on where you end up.
Yeah, I had a similar life experience of getting I was out of fellowship, but I was an associate at a practice, Head and Neck Surgical Associates in Portland.
Mhm.
Eric Dirks,
Yeah,
Brian Bell,
a big group.
Bryce Potter, those guys. And Eric had set up a case for me that, it was some crazy case like you're describing. It was this crazy ankylosis case, and it was someone who kind of sought out kind of the experts for that. And I was right out of training, and I'm like, I'm the expert. But you have to be the expert at some point, right? Like getting into that situation, because otherwise, finding yourself, you won't find yourself in the expert role unless you do it. So I think that's to me a big advantage of joining a practice like that is you have the opportunity to access those things. Because Wasson had to just, you know, make it out of thin air, right? Like you had to convince people that you're the right guy to see.
Yeah, and in a tough area to do that. At that time, especially. It wasn't easy. I mean, I even find it here in Arizona a little bit difficult, and I think there's some other variables that go into play with that. But it is. I mean, I would have probably rather had you guys scenario, but maybe that's easy for me to say, just because I went through the other way. Maybe in hindsight, it was the best thing. But I mean, I am kind of interested in that because it does seem like it would bring things your way, and also you would have the ability to lean on those other people, right? Like, here's what I'm thinking, here's what we've done in my, I'm the avascular necrosis expert. Here's what we've done. Is this in line with what you guys would do? I mean, that there's value in that, whether they say yes or no. Having that discussion, have people lean on, and then absolutely what you said about having expert hands in the surgery. Oh my gosh, like that just I dream of the day that I consistently have that scenario. I think that's all of our dreams.
I mean,
Uh,
Omar, you're doing trauma on your own, or do you have another set of hands?
No, trauma usually, we have a ENT residency where we're adjunct faculty, so I'll get the residents involved. If it's a really, like we had a big pan face, like a real trauma that, I had one of my partners come out and give me a set of, another set of hands, just because it makes everything more efficient.
It is a different world doing cases on your own.
100%. My first like symphysis fracture, like straightforward, minimally displaced, just operating alone or with a scrub tech that is, an orthopedic surgery scrub tech.
Yeah,
It's so difficult.
it
and
is
that's the
so
worst
different.
part about trauma. It is like it doesn't come in on regular hours. So like you're doing it after hours, usually with a team who, through no fault of their own,
Yeah.
isn't used to working in your field, let alone with you. And so there you are at 7 at night or 2 in the morning, as you just said, with the orthopedic backup, you know,
Yeah.
scrub tech, trying to get through, even something simple can be painful.
Because
And I think that's why a lot of people don't do trauma. One of the
because at
reasons.
Parkland, did you ever have experiences of just you? You always had like an intern or always like another one of your
Multiple.
co-residents, right? I mean,
Never alone. Multiple sets of hands, especially the good cases. You'll have like
yeah,
a chief or two of fifth years, an intern. The attendings were very hands off, which I'm very appreciative of now. But no, you were never alone. You always had good retractors. You can, you know, set the toe up or what you could put things where you want it and it would stay there. And like I don't understand when you guys are doing like a sagittal split and you're plating the mandible, like how do you hold the proximal segment and
it's
then I
like
don't
a
know,
whole operation on its own. I really think learning orthognathic surgery on your own is like it seems like a different operation.
I can't even imagine. Or just like you guys do position screws first, right? You don't put the plate on them.
No. So that's what, so this is
Like,
our frequent discussion. And was this on, I don't know if we did this on a recording or if it's just you and I shooting the shit, Sam, but I do what you described. If I'm doing both positional screws and a plate, which I typically do, I put positional screw in first because I think that's easier. Sam feels the opposite. He feels it's easier to put the plate on
I don't have
first.
enough hands to put in positional screws.
So walk me through it. So you have like like a pickle fork or something holding the condyle in the position, and then like how do you do it?
Oh, so for the reason why I think the plate's a bit easier is you really just have to hold the proximal segment with the toe out. So I generally use a medium toe out at the inferior border to allow for bending of the plate. And then after that, I can either use the toe out or I can use the pickle fork in the plate or the proximal segment. So either one of those to hold it in place. But by now I can use the medium toe out well enough to hold it in place. And I think the interference management, so you're not like pivoting off one point, you know what I mean? So it's like, so it isn't rocking or it isn't just like unstable in other ways. I feel like if you can have a relatively even contact, that helps out a lot with that. But it is, I'll tell you, I struggled with that for a while. I mean, because I trained like you did, and I learned jaw surgery with a lot of hands, and then all of a sudden I was like, why am I having such a hard time? It's
That's
like,
hard.
oh, I'm missing hands. Like I just have two hands now, and then it's like, well, how does this happen? So it's a lot of like self-retaining retraction and approaching it in different ways. But I do feel like solo or semi-solo jaw surgery should be something that's taught. Like it should be something considered in the overall scheme of things because at some point you'll come across it, right? Like you're a surgeon that's helping you out isn't there or sick or just something comes up and maybe you think, well, I can probably handle this two jaw, and it really is a different operation. So
I can see that for sure.
um but anyway, getting back to your pathway of training and all that sort of thing. Do they have TMJ people there, or was that something that you brought in?
So they did do TMJ surgery. One of the senior partners here, the guy who started the practice, Stephen Kupferman, was doing arthrocentesis arthroscopy. and him and Jay Lee, one of the other partners, were doing total joint replacements. But I think I came in focused on trying to increase that portion of the practice. And I'll say that I probably see more TMJ consults than anyone at this point, just because, I've kind of carved that out. And once you start doing something, the referrals and the patients start talking to each other. So that's been a nice thing to add on. But you bring up a really good point, is like, as a new surgeon joining any practice, you really kind of want to bring something to the table. And although this practice is full scope and offers everything, I wanted to be able to like differentiate myself amongst the other people and add value, because ultimately it's like, this is a job. I need to make sure I'm doing my job well and
Yeah.
increasing productivity and bringing new things on. And I think TMJ was kind of my way to do that. It also helps that I enjoy treating those patients, like I'm sure both of you do. Like it's hard, it's rewarding. It's hard, but it's rewarding. Like, kind of want to figure out your algorithm. Like, Mike, I think you did the TMJ mini residency, it said, right?
Yep.
Yeah. So one of my partners here did that too, and I think that that's the best place to learn how to manage TMJ, unless if you're in a training program that has really good people doing it. Because otherwise you get out, and I think most oral surgeons will do an arthrocentesis. I think very, very few surgeons offer arthroscopy or, TMJ replacement. And you can't really dabble in those things. Like if you're doing, 3 or 4 arthroscopies a year, 3 or 4 total joints a year, you know, at some point it's like there's gonna be better people out there to do that. And it's probably not worth your time to like cling on to it, in my opinion.
Yeah.
Yeah. Unless you're just in an area where that's all you've got, like that's all the community has, and
Yeah,
like you're
exactly.
the only one. I mean, but yeah, otherwise I think that's the model of trying to set up specialized centers for these things like they do in other disciplines and specialties. But I don't know that our world can go to that
Yeah.
truly.
TMJ
Um,
surgery itself's kind of interesting just because it overlaps so much with orthognathics. But like what we're talking about with single operating, I mean, you can do TMJ surgery almost always on your own.
Yeah.
I mean, with the exception of complicated TJR, it's like the opposite issue. I found that TMJ arthroscopy was like one of the hardest operations to learn. What do you guys think about that?
Agreed.
Omar, you can figure it out pretty easy, or
No, I mean
that
it's
is hard.
easier on a cadaver than it is in a real person. I think I think with the right training, and I'd love to go back to that same Nexus CMF course to try to figure out the level 2 and 3 stuff, but it's hard. It's like trying to do laparoscopic surgery. Our hands don't work that way. We're used to big incisions and being able to see everything directly.
I mean, I think you can learn arthroscopic lysis and lavage pretty quickly. Like
Level
if you have
one.
some background in the anatomy, yeah, like you're saying, level one, whatever you want to call it. But I would even say, I mean, like we have our kind of epiphany moments. Like getting into the anterior recess is not easy because most of the time the people who need it have pathology and their joints are restricted. There's something you're there for a reason most of the time, and just subtleties of getting in there and getting your other instruments in there. And it's such a tiny space. I'm with you. I think that's one of the hardest things to learn. And then I think there's almost like an aha moment where it suddenly, I don't want to say becomes easy, but it becomes easier. Sometimes I feel like I've had that moment and then I'll struggle a time or two and then I'll have a success and I think I've reached it. But I would agree. I think that's a difficult operation to do and learn. And I think it's also hard to teach, right? Because it's such a small space and only one person can have their hand on the instruments. And I don't know. I don't know. I would agree with that sentiment. And I think it's the TMJ MIDI residency was very good at it, but there's still limitations. You still got to go out there and get your own reps in.
Yeah. I mean, I thought it was a few years at least before it was like I was doing what I thought I was doing. I know that sounds silly, but like I could reproducibly do what I wanted to do. I mean, by now, it's comfortable, it's pretty straightforward, but I generally found that learning curve to be one of the more difficult ones when it came on to getting done with fellowship and getting on with life.
But you brought up a really good point about how intricate the like connections between TMJ surgery and corrective jaw surgery are, because like think about how many patients you have that pop or click after a corrective jaw surgery, or talking about rehabbing BSSOs or trying to get people with their mouth opening back, or random aches and pains. Like, you can't really just do a sagittal split and a Lafort and then never see the patient again. Like, some of them will develop TMJ issues, and you got to be able to triage them and manage them, I think. Um,
Yeah, so that's great
Agreed.
if you're doing both.
it's
Yeah, I think that it's a good thing to bring to practices by having some TMJ experience, because I think every practice needs good practitioners for that. So that's great.
Well, I think also fundamentally makes sense from a business standpoint, as Omar was kind of saying earlier. I mean, it sounds like there was already some being done, but you know, as I've told people, and maybe I've said on this show, in my experience, I've had residents and dental students ask, how do you set up a TMJ practice and how do you make a successful TMJ practice? And the answer really is just open one. Like, there's such a need. Like, the people will find you. Like, jaw surgery, you need to go out and meet orthodontists, market.
Takes a while.
You need to do that for everything to an extent. But TMJ, if it just becomes known that you do TMJ surgery, they will find you. And like, it's a way, like trauma, to kind of always say, hey, there's going to be economic highs, lows. There's going to be shifts in the way that practices are run. We have increasing DSOs and private equity and all these other things going on. But like, those people aren't wanting TMJ. The guy down the street's not wanting to do TMJ. And so it makes a lot of logistical sense from just a purely practice and business standpoint to take that on if you can do it and you are willing to, because it is a challenging patient population. But from a career standpoint, I think it has a lot of value um, to bring to any practice or on your own.
I think.
I'm gonna
Oh, go ahead, Omar.
I said I'm gonna put a statement out there and I'll see if you guys agree. I think the TMJ population is easier to manage or to work with than some of these sleep apnea, OSA, or just jaw surgery patients in general. How do you
I
guys
would
feel
agree.
about that?
I agree.
Oh yeah,
Yeah,
yeah.
so
I mean,
And I don't
that
think it's
sounds
close.
probably crazy to residents who might be listening to this, but that is absolutely true in the real world.
because I think I learned this in residency. Those patients, man, those fibromyalgia and myofascial pain, you'll never get them better. But like, if you know how to diagnose TMJ disorders properly and understand who the good surgical candidates are and who the people you just can't help are. Like, you don't have to see them forever. You can refer them to a PT or a myofascial pain specialist. But the obstructive sleep apnea and some of the orthodontic patients are really, really, really difficult to manage. And um, it's totally elective surgery. Like you mentioned, a mandible fracture, they came in with a broken bone. You can't really mess it up. When someone comes
You
in
can.
I mean,
elective surgery,
I've worked with Sam. I can assure
it's
you that you
possible.
can.
Um,
But you're speaking the, I mean, I agree with you in totality, because like you're saying, you're treating a true kind of almost, this isn't the right way to word it, but you're treating a true pathology that if you can remedy the pathology, uh, the patient has an improvement from when you met them. And that sometimes can be challenging in more elective procedures. And operating on a healthy teenager and having complications for something that maybe didn't have to be done, that is very stressful, and that is nerve-wracking. Whereas someone who's in daily debilitating pain or having pain, limited function, limited diet, limited social interaction, missing work, missing school, if you can even improve them
yeah.
some, they are grateful most of the time. They are happy. If normal opening is 35 to 50 and you get them to 33 from 15, they are grateful. Whereas, especially in going back to our recent talk, Sam, with social media and the changes of attitudes of patients and what they're looking for and how much they scrutinize things, gone are the days of, hey, my teeth fit together and I'm happy. Um, and so I'm with you. The orthognathic patients, I don't find it as much for the OSA. You mentioned OSA. I mean, I get that a little bit, but it's the
I
the
mean, it
very
could be.
detailed.
I mean, I would also a little bit with the OSA, but it's generally the symptom that there's not enough space in my mouth for my tongue. That symptom is so subjective, and creating an objective result there? Like, do we need 10 millimeter intermolar space increase? How does the palate change? Where does the base of tongue move? All those things are too many variables to influence that subjective symptom.
And sleep and OSA is not all about just the position of the jaws, it's
Yep.
there's a lot more to it. So
Yeah.
but I mean, for any of any of the listeners that are in residency or considering joining a full scope group or doing broad scope surgery, I can't tell you how awesome it is. Like, it is so nice to have, a jaw surgery one day and then wisdom teeth and implant. I mean, just having the variety is incredible. Um, it's very good for a business from a business aspect. It makes your practice or your future, partnership practice almost like recession proof, because you're offering things that other people cannot. And everyone wants to talk poorly about trauma, and yeah, there's some belly aching along with the block time like we talked about, and low reimbursement or no reimbursement in many cases. But you also take care of people who end up coming back for dental implants or routine dental alveolar or more lucrative procedures. Not everything's about money, but like, at a certain point you got to run a business. But trauma is a way
As
to.
a young surgeon, I would say you want to do that when you get out. Like if you take a break from doing major surgery, it is difficult to get back into. From a lifestyle, from a 8 to 5, now I'm all the time perspective, your skills, your comfort level goes away. Um, I think everything that you said is true. Oh man, there was another point I was going to make that piggybacked off what you said, but I forgot. Sam, chime in here and try to
Well,
contribute
because
for
what
once.
I was thinking about is more, I mean, yeah, your practice sounds great, by the way. Was more tapping into your expertise on avascular necrosis of the maxilla. That is something I still haven't seen actually. I saw that once as a resident, but I was like peripherally involved.
Not knocking on wood here.
Tell us
Yeah,
what
tell us about
tips you
that.
got for me. What do you got? Because I know that problem to be as soon as you're suspicious, you take out splint. Um, take
I want to show you. I'll show you guys the case offline, start to finish, because it's an awesome case. But
do HBO, massage the gums, Vaseline gauze.
so
Through all the things I know of.
this guy was 6 months out from his initial surgery. So
This was the case you're referencing about the
17 millimeter movement.
country type of thing.
yeah, so he came in 6 months, 7 months later. So no amount of HBO or any treatment was going to help him. So he was just like a debridement and a buccal fat pad for fistula closure, and
What segment are we talking about right now? Like,
left upper
okay.
left. Um,
And he lost the left posterior segment.
So the entire left hemimaxilla was, he came in, you could smell it when he walked in the room, and he's got
6 months post-op.
Yeah, yeah.
Oh wow.
His other surgeon, you could see. I'll show you guys the case, but basically during that initial operation where I extracted teeth 9 to 15, debrided the dead bone, and did a buccal fat pad for the fistula closure, there's a piece of bone that has little burr marks on it, and it looks like the another surgeon had opened up the tissue and basically put some burr holes in the bone to encourage some bleeding, and then they had stitched the mucosa to the arch wire with Vicryl sutures, just trying to drape it down. That didn't really work very well, and the patient was in pain and whatnot. So anyways, the first operation we did that, and then he was still very bimax protrusive, so it was really sad. Like, the mom was saying that he'd cover all the mirrors in the house and taking like hundreds of photos of himself. So we actually did a revision eye jaw. We set his maxilla and mandible back, a little bit of a clockwise rotation. He was a 17 or 18 when he first came in, so he's grown a little bit since then. I treated him like 2 years ago, 2.5 years ago. But we did his revision MMA, and then once he healed from that, we did an anterior iliac crest bone graft to the left maxilla. And then once that finished up, finally we got the implants and the final teeth in. But you're talking about like 2.5, 3 years of treatment. And he came in my first week of work. It's almost been 3 years now. But back to what you were saying, HBO therapy is helpful to delineate where the necrosis starts and ends. It doesn't do much to save any tissue. if it comes, the first day post-op, we keep our patients here overnight in the surgery center. We see them the next morning. If someone's got a white maxilla, if it was a segmental, then yeah, I would take the palatal splint off. And if that didn't do anything, I'd probably take the patient back to the OR, take the plate
That
off.
I have an impression that practice is something that doesn't actually happen. Have you taken out a splint for that reason?
I've thankfully never seen like a white maxilla post-op day one.
Yeah, because I mean it's such a rare thing. It's like there's a number of rare complications. It's nice to hear from people who've seen it a few times because it's hard to know, right? Like you need to do something a lot of times to figure out what's the correct pathway. And I think the secondary reconstruction, like treating it like a anti-resorptive osteonecrosis case, and except in a otherwise healthy person,
Yeah, thankfully.
that makes a lot of sense. But the initial kind of management of it, it's very kind of like hand wavy, like Wasson, like do you see that sort of thing? Are you just doing the stereotypical board answer kind of management?
Yeah. Yeah, I would splint out if I had IMF screws or other things in, I'd probably take those out. I'd probably take everything out. I don't I've always debated the going back to the OR. Like, I mean, you've heard that, like, hey, you go back and you take out the hardware and you basically try to put everything back where it was. And it's like, well, I don't, maybe that helps. Like, I don't know. I don't know that that's the answer. I've heard that, I've come across that, like, because, well, if you're lacking vascularity and it's due to, if you lost a vessel, that's probably not going to help. If it's because you're stretching tissue and you're decreasing the vascular supply, maybe that helps. But I mean, I would also just throw in there, like going in there and mucking around again probably doesn't help the overall vascularity. Um,
yeah,
and
I
if
don't know. I
anything, it might
mean,
hurt it. I don't
this
know. I could be convinced both ways.
the scenario that Omar's describing of a 17 millimeter expansion, I mean, or advancement, that's aggressive. And
Yes.
I've stretched maxillas a good distance, but 17's a good distance. So I mean, what you're describing might be, you know, a
In
reasonable.
that situation, I might, yeah, in that situation, I might consider it, especially if I knew like the vessels weren't taken.
I feel like
Like,
we're talking about this more. Omar's the expert. How many of these have you seen
yeah.
since that one? Have you started getting referrals from online crews and that sort of thing?
No, no, no. This patient's not the type to jump online and
Oh, no, no, but like since you've in your practice in LA comms, I assume they get other referrals from other spots. Have you looked after a few more patients for
I
that?
I've seen one other patient with like, in the interdental osteotomy, you have a periodontal defect and bone loss. This is like now years after corrective jaw surgery. I think that's technically still an avascular necrosis. Pink or discolored anterior tooth after segmental LaForte. I guess technically that's like an avascular necrosis sort of complication, but nothing as big as that one that I just described.
Discolorating the tooth, I think is I don't know if that's. I mean it could be for the individual tooth. Is that what you mean?
Yeah, basically lack of blood
Because
supply
that
from one
that
individual.
happens like all the time. Have you
Yeah,
seen that paper from South Korea?
what did they publish as a percentage?
Because they had a comparison to taking the vessels or not taking the vessels. And they do so much dang jaw surgery. It was something like taking the vessels got you around 10%. It was like 8-10%
Yeah.
per patient would have a discolored front tooth. And then
Wow.
if you don't take the vessels, it was about 2 or 3%. And they standardized for segmental and everything else. But yeah, I mean, I think that discoloring a tooth, including that in avascular, is like
A
it
little
it
aggressive.
becomes like a 1 in 5,000 complication to now it's like a, you know, 1 in 10, right?
Yeah.
Potentially. So yeah, that's wild. Sorry, I derailed our original discussion, but I wanted to chat to see if I could learn
I
a
mean, I
few
think it's an
things
interesting
about it.
topic.
Yeah, I think it depends
Um,
on the case. Like if you did a segmental before, not huge movements, but you did a big tipping of the anterior segment, and post-op day one, you see the anterior segment is blanched or it's congested, then I'd probably take that patient back. And because the thought is that there's some kink in the vessel or in the palatal mucosa, like that's a patient I would take back and take the fixation off and see if I can get the maxilla to perk up. But I also see what you're saying, like mucking around again is not going to help the blood supply.
But yeah, what if you took one of the two vessels or accidentally had to
Yeah,
take them, and now you go back and the other one's gone? Um, I
yeah,
mean, I don't know. I mean, like I could see value in going back if you thought there was something like, well, let me back up for a 17 millimeter advancement. If that was happening,
yeah, yeah. I agree. I agree.
I would probably maybe take that one down and move it back. But like just normal case, like a lot of these in the literature described, a lot of times they're not crazy things going on. And so I don't know that taking them back. So I think I would even consider, I mean, what are you guys' thoughts on adding pentoxylin, vitamin E?
Or nitro paste, you could rub some
Yeah,
nitro paste
I
in.
mean, it can't hurt, right? I
right.
mean,
It's
the
pretty
data is
benign.
not terrible on or end management, but I mean, I think trying out as best you can to do the things at the beginning to intervene is a great idea. So well, sweet Omar. How old's your kid right now?
I have a almost 5-year-old and almost 3-year-old, so
You
five
have
and
a
6.
5 and a 3-year-old at home?
I look like I'm 22 years old, which doesn't instill a lot of confidence in my patients. But yeah, I'm 36. I got a 5-year-old and a 3-year-old.
Yeah, that's a hard stage for kids. That's great, man. But just so you know, it only gets better once they get older. 5 and 3, you haven't had good sleep in like 5 years, and then with residency, you haven't had it in like 11 years. Um,
And taking trauma call, man. I mean, and you're on essentially Q2 at
you're gonna
level
be
one. You just don't like sleep, man.
you
No,
stop.
I'm not that kind of guy. I'm not the you know 3 hours a night and I'm functioning well. I sleep as much as I can.
Yeah, that's great.
Yeah.
Well, great. Yeah, so we should finish up so you can get home to your family. Appreciate joining us today to give us some insight to the different pathways right out of residency. And like I was saying, it's great that you're doing that. So stick with those guys. I'm sure you're learning lots of stuff and appreciate the feedback on things because part of this for us is like learning our blind spots and learning extra stuff from other people. So thanks a lot for doing that.
Yeah, I think we're frequently fond of saying like, or at least I am, the more I figure out in this world, the more I realize how much I don't know. Like you come out of residency doing a bunch of cases and you think you got it figured out, and then it's like, huh, maybe I don't got it all figured out. So it's nice to hear other people's perspective. And yeah, I'd be interested to see that case if you got time to show us. But yeah, thanks again for coming on. That was another Down Fracture podcast for Talking Jaws, downfracturepodcast at gmail.com. And we will see you next time. Thanks.
Thanks, guys.